Good afternoon, everyone, and welcome to the McCann Markey Cancer Center Affiliate Network COVID-19 web series. Today, our topic is Oncology Rehab amid COVID-19. Before we begin, just a little housekeeping rules. Everyone will be on mute throughout the presentation. At the end of the presentation, you can submit questions during the presentation via the chat box. I will send everyone a good afternoon chat. You should see a flashing cursor at the bottom of your screen. And then you can submit questions to me. I will repeat the questions back to our presenters today. So let's begin. I'm going to introduce our moderator. Our moderator today is Miss Sherry Toll. She is the she is the director of the Markey Cancer Center Affiliate Network. I'm going to mute myself, and Sherry, it's all yours.
Thanks, Jerome, and welcome everyone to the Markey Cancer Center Affiliate Network's COVID-19 and Cancer web series. Most of our programming is developed and offered exclusively for our McCann members, but due to the emergent nature of COVID-19, we've opened this web series to those outside of the network. So if you're new to our McCann educational programming, welcome, and we're very glad that you're joining us today. As Jerome mentioned, our webcast today is Oncology Rehabilitation amid COVID-19, and I'm delighted to introduce our three speakers. First, Dr. Megan Nelson is the Medical Director of Cancer Rehabilitation Medicine with the University of Louisville Health. She's a physical medicine and rehabilitation physician with specialty training in cancer rehabilitation medicine. Dr. Andrew Savoie is an assistant professor with the Physical Medicine and Rehabilitation Department at the University of Kentucky. He also serves as the medical director for the Markey Cancer Center Oncology Rehab Clinic. And Audrey Stockwell has a doctoral degree in physical therapy and is a board-certified specialist in orthopedic physical therapy. She specializes in working with oncology patients and is a certified lymphedema therapist. I know many of us miss our sports, so this is an opportunity to get UK and U of L together, but hopefully we're going to be not necessarily competing, but having a good time together and sharing some great information. Welcome to our speakers. Thank you for sharing your time and expertise with us. And just allow me to get started by mentioning the obvious. COVID-19 has changed life as we know it, and we're adjusting to this new normal, and it can be difficult, especially for our patients with cancer. And we'll be interested to hear some of the implications of COVID-19 on oncology rehabilitation and what types of rehab services are still available to patients with cancer given the current business and social distancing restrictions. So I'll turn it over to the three of you.
Thank you, Sherry. This is Megan Nelson. Hello, everyone. As we all know, the novel coronavirus knows no boundaries, no barriers, no divide. No divide like our red-blue famous divide here in the state of Kentucky. So I work at U of L, but I did graduate from UK Medical School, so I kind of crossed that divide. And then and Dr. Andrew Savoie, as she mentioned, works at UK, and as long as he and I have known each other, we've had a great professional bridge. Audrey on the call as well, works with Court Rehab, and all three of us have a great professional bridge, and we're so glad the three of us can come together and present, no matter boundaries or barriers, about this important topic of oncology rehab. So I'm going to start off a little bit about the history of cancer rehab, what that really means before we get into the nuts and bolts about the implications of COVID currently. Just to give a framework of cancer across Kentucky, here in the year of 2020, the estimated new cases of cancer in our state is greater than 15,000 people with new diagnosis. And that does not include the patients who have had cancer diagnosed in years prior or patients who are currently going through treatment, as well as those who have completed treatment. Estimated deaths from cancer itself in 2020 is greater than 5,000 people. So as we all know, cancer does not stop for the coronavirus. So why is oncology rehab important? And it's just as important as it ever was right now, because we do know that performance status of cancer patients directly affects whether they get treatment or not for their cancer. If someone is not having a good performance status, not functional on a day-to-day basis, treatment may be withheld because they may not do well with the treatment. So performance status directly improves treatment completion rates for their cancer. We know that performance status, if it's good, reduces disease progression and death from all causes. And it's being shown more and more that there's an inverse association between physical activity and cancer mortality. And obviously performance status directly affects patients' quality of life. And there was a large study on 90,000 cancer survivors that showed the leading cause of distress for these patients was their level of disability, even above the stress of the cancer diagnosis itself. So when people think of rehab physicians like Dr. Andrew Savoie and I, a lot of times people will automatically think of certain diagnoses in certain places. One place in Louisville that people think of a lot is Fraser Rehab, which is associated with our academic cancer center. People in Lexington may think of Cardinal Hill a lot. They may think of these 4 diagnoses listed on this page, one being spinal cord injury like Christopher Reeves, or brain injury like Abby Giffords, or amputee patients like Oscar Pistorius. Another very common diagnosis to think about is stroke. But the reality is cancer patients can have presentations that are similar to these sort of patients based upon where the cancer is located, based upon the treatments they receive. So if you had to look up the definition of what cancer rehab is, you'd get a broad definition because cancer rehab is broad. The goal of cancer rehab is to improve function in 4 domains, not just the physical function, but also the social function of the patient, the psychological and vocational functioning of the patient. So obviously to impact all those different types of function for patients, you need a team effort. So a lot of people are involved in the cancer rehab team. And there's a laundry list of rehab needs of cancer patients. I'm not going to go reading off all of these right now. The main purpose of this slide is to show that just any patient with any cancer diagnosis can have rehab needs. And the research shows that greater than 60% of cancer patients have at least one rehab need, one functional impairment. So when you think of rehab, a lot of times we think of physical therapy, occupational therapy, and speech therapy. So why is it important to include physicians like Dr. Savoie and myself? Why is a cancer rehab doc helpful? We, on a daily basis, are seeing patients to try to figure out what is the etiology of the functional impairment of patients. And typically it is multifactorial. It could be because of the tumor burden. It could be because of side effects from the cancer treatment, but it also can be comorbid conditions. And so we're ordering diagnostics to help elucidate what is the etiology of this functional impairment, which then dictates the referrals that we provide, which includes therapy and many other referrals. We use medications to help improve function for patients. It may be medications for musculoskeletal impairment, neuropathic issues, cognitive decline, etc. And we also use procedures focused specifically on improving function. And we'll talk about a few of those. So cancer rehab really isn't a new service. It really started to increase around the 1960s when fortunately our cancer treatment care was showing improved survival in cancer patients, which then elucidated that these patients were having functional issues because of the cancer and its treatment. And now today, fast forward, there are 8 cancer rehab fellowship programs across our United States. So here's an example of how cancer rehab and cancer rehab physicians can help. A breast cancer patient, for example, the one who is shown on this picture who's had bilateral mastectomy, may present with shoulder pain. You may automatically think, well, maybe it's because of the surgery, and that's a very valid point. But there can be multiple other things that are coming into play for that shoulder pain. So you really need good physical exam, diagnostics as well, and you may need referrals for therapy in addition to medication management, and then prolonged follow-up with this patient with a cancer rehab physician. One thing that can cause pain in breast cancer patients as well is a radiation side effect called radiation-induced spasticity. The pectoralis major muscle may be exposed to the radiation, and what can happen is you can have fibrosis and tightening of that muscle, but you also can have spontaneous muscle contractions and muscle spasms. So we found that for some of these patients, you end up having to utilize also injections with botulinum toxin agents, which essentially reduces the acetylcholine release. It blocks that acetylcholine release from in the neuromuscular junction. So you reduce muscle spasms, thus reduce pain and improve function. There are other patients who have radiation-induced spasticity as well, including especially the head and neck cancer population. They may have a painful oral trismus, they may have cervical dystonia, and those patients may require injections as well with botulinum toxin. Another type of patient that we rehab physicians may treat for spasticity as well are, here's an example, a lady with a glioblastoma, a brain tumor, who had left-sided weakness because of the location of the brain tumor, and she was falling very often. They were obviously worried about recurrence, so they were doing imaging, they were providing steroids, and imaging was stable, no other interventions were helping, so I ended up seeing her in the clinic. She presented in a wheelchair, which she had been presenting to most clinics in a wheelchair because of her fear of falls. We got her out of the wheelchair, and then that's when we quickly noticed the spasticity and the plantar flexion tone. And that was causing majority of her falls because she was tripping over her toes. So what we were able to do was provide botulinum toxin injections to the gastrocnemius muscles and provide an AFO, and she had a drastic reduction in falls, thus an improvement in quality of life, and she got out of her wheelchair a lot more. So as I'm going to be transitioning to Dr. Savoie and Audrey to speak, obviously there are a lot of different rehab options across the continuum of care. And from our inpatient side, including places like Cardinal Hill and Fraser Rehab, inpatient rehab has continued with this during this COVID episode. There have been some elements that have been helpful, including, you know, obviously patients and staff wearing masks and gloves, but inpatient rehab has continued for sure. Outpatient rehab, we'll talk more about with the other speakers. They have had to adjust more with the telehealth and having some in-person visits based upon emergent and urgent needs based upon Governor Beshear's mandate. And then home rehab has continued with home health services. And then physiatry, cancer rehab physicians like Dr. Savoie and I have continued to care for cancer patients via telemedicine during this time. And regarding telehealth, patients do want it. This slide is actually pre-COVID times, looking at how willing patients are based upon their age to engage in telehealth. The blue bar is how willing they are. And my suspicion is with this COVID time, those blue bars are probably expanded in the willingness of patients to engage in telehealth. So that's it for my portion. I will pass the quote unquote mic off to Dr. Savoie.
Thank you. So my part will be to go a little bit deeper into what we've been doing around here in terms of the changes. So next slide, please. This slide is a demonstration of some of the things that I tend to see on a more frequent basis at UK. I won't go through the list, but there are a number of different diagnoses that tend to occur as a result of cancer treatment, surgery, chemotherapy, radiation, and we see quite a number of things. So go ahead, next slide, thanks. Like Dr. Nelson mentioned, the inpatient side has still continued to chug along. So while some of the changes to inpatient rehab facilities has been directed toward the diagnoses they're allowed to accept, the number of patients with specific rehab diagnoses that they're supposed to maintain, a lot of those things have been lifted. And the reason is because during the preparation time for COVID pandemic and looking at the projections, there was a concern that should the acute care hospitals become overrun or overburdened because of patient need, that they would potentially be used as additional facilities or non-COVID hospital admissions. So many of these facilities ended up sort of leaving spaces open in anticipation of a wave of patients that may or may not need rehab. And thankfully, so far, we've not gotten to that point. I don't know that our peak will get there, but we'll see. We continue to do a good job with social distancing here in Kentucky. The question becomes then, which patients really need it? You know, the man who's fallen off his ATV and hit a tree that's on the inpatient side, he more than likely will transition to inpatient rehab. That pathway is remaining open. On the outpatient side, there are some things that tend to have more serious sequelae if not treated early. Some of these things include lymphedema. Any cancer patient with worsening functional status is usually a tip-off that something just isn't right. And often the patients and the caregivers know that something just isn't right, but they're not quite sure what that might be. Sometimes it can be a recurrence. Sometimes the patient is falling more. And when these things are happening, they are of higher urgency because of the potential things that can happen. Hip fractures, head bleeds, worsening dysphagia leading to an aspiration pneumonia. These are all things that could potentially land a patient in the hospital. We also don't want to forget that there are essential workers that are cancer survivors. And so as their schedules have changed, as their requirements have changed, they too may have exacerbation of symptoms, or they may require additional evaluation in order to maintain their frontline or essential worker status. And what this really boils down to is that most of the patients need to be addressed on a case-by-case basis. Like Dr. Nelson had in a previous slide, the quality of life indicators tend to be more distressing to the patients even above the cancer diagnosis itself. And so what may be urgent for one patient may not be as urgent for another patient. So in the times of COVID, you know, we're going into this rephasing or reopening things slowly now. So face-to-face or telemedicine, in my practice, I've actually come to quite appreciate the telemedicine option for some of my patients that may not need a more thorough physical exam. It's very easy and convenient for them. They're able to use it on their phone. I've had multiple people in the car that they phone in when they're on their way to whatever they need to do, and then we get everything done. Next slide, please. One of the more recent studies done by one of our PM&R colleagues at Mayo was this study regarding the impact of telerehabilitation with monitored follow-up versus not. And so they had a number of patients, I believe somewhere around 600, that were divided into 3 arms. Arm 1 was monitored over a period of 6 months, just as arms 2 and 3 were, but they received no sort of telerehab or telemedicine instruction or rehabilitation. Arm 3 included telerehab, but also attempted to manage their pain with telemedicine and use of opiate medications, whereas Arm 2 was based primarily with telerehab and use of modalities, non-opiate pain interventions. And they found a good improvement with structured telerehab with consistent follow-up. So it does work. Here at UK, the strategy that we took was to go through the individual clinic visits and determine based on either what they were being followed with or the new complaint that was being, with the new issue, and to figure out if they would potentially be okay for telemedicine. Medicine refills, relatively stable symptoms were deemed okay for telemedicine, since a physical exam would probably not be as instrumental. Some of our more serious folks with balance impairment or those who may have an essential need and not be able to tolerate their shift at work were deemed not appropriate for telemedicine. They needed to be seen in person. So those patients were called, decided if they could participate or not based on their current technology and understanding of how telemedicine works. And then if they were not able to do that, they were given the option of either waiting, if that was okay with them, and if it was deemed that they could potentially wait, or to come in based on their urgency. The treatment options are open, and TELEREHAB hopefully will be around for a bit. In Eastern Kentucky, there's a significant need for therapy services, and they're not as widespread as you would like. So having the option for a TELEREHAB visit, even if that was just intermixed with face-to-face visits, would remove a significant amount of travel burden that some of our patients have. So a quick case, this is one of my fellows who follows with me for a bilateral radiation-induced brachial plexopathy. When I met him, he could barely move his arms off of his lap. He couldn't put on a shirt, couldn't feed himself. His wife was his caregiver and basically doing just about everything he needed in terms of ADLs. He had received some chemotherapy, some radiation, and over time, he'd been getting much better. So his arm strength actually improved so that he could do some of these things by himself. But when I saw him on the telemedicine, he started complaining about a new mass that had popped up around his neck and shoulder area. And even on the screen, it was pretty easy to see. So what started as a seemingly routine telemedicine follow-up ended up being more urgent. We requested that he come into the clinic to have me take a look at it. At the time, there had just been an order that elective imaging really needed to be placed on hold so that we wouldn't overpopulate or overburden the imaging services that would potentially be needed for COVID. So that was sort of throwing a wrench into the mix. So I asked him to come in. We placed the ultrasound on the area, and as it turns out, he had a really significant thoracic kyphosis. So he was kind of hunched over for a long time. And as he had been rehabbing his posture and his upper extremities, he had started to stand more upright to the point where the upper edge of his scapula started coming up too as a result of his improved posture. So what he felt as a new mass was actually repositioning of his scapula due to improved posture and better upper extremity strength. So it was a nice visit. We got to clear him of any potential recurrence or new disease. I said, yeah, this is a bone. You don't have anything to worry about. You're doing really well. And so it was good. Next slide. Thank you very much. It'll go next to Audrey, who's going to help us learn about TELEREHAB.
Great, thank you very much. So yes, my name is Audrey Stockwell, and I am actually the Revital Cancer Rehabilitation Director for Court Physical Therapy. And like Drs. Nelson and Savoie, I'm going to talk about how we can navigate oncology rehab during a pandemic, but I'm going to speak more from the position of outpatient therapy. So next slide, please. So when trying to decide how to best treat oncology patients during these times, it's helpful to have a guide. And this clinical decision-making algorithm is based on the OIG of Kentucky guidelines to help determine course of care. And it classifies patient cases into urgent, essential, and all other patients. In examples of oncology specific situations that would be urgent, Dr. Savoie already alluded to this a little bit, but would be acute post-op patients, someone with really acute pain that might lead to an unsafe situation or functional decline, high fall risk, acute onset of lymphedema that might lead to cellulitis or, again, significant functional decline, acute, significant dysphagia. So we've talked about all of those. And then the essential category, again, like Dr. Savoie mentioned, would include essential critical infrastructure workers. So you can see on this algorithm, if a patient falls into any of the categories, then you would consider the risk factors for COVID-19, which I'm going to discuss on the next slide, and then make a decision as to where the patient should be seen. Should they be seen in the clinic, at home, or utilize TELEREHAB services? With patients that fall into the urgent or essential categories, then the preference would be to be seen in the clinic if the risk factors for COVID-19 do not outweigh the benefit of them being seen in the clinic, since it is an urgent or essential worker. For all other patients, even though we are this week, as of this week, started to do some phased opening of outpatient PT, OT, speech clinics, the preference still is to try to see the patient in the home or telerehab services at this point. Next slide, please. So this is the current list of high risk factors for COVID-19 per the CDC. I've bolded on here immunosuppression and cancer, as this is the population that we're talking about. However, it should be noted that many of our patients in the oncology population have these other risk factors as comorbidities. But please note that just because a patient has one or more of these risk factors does not automatically preclude them from being seen in the clinic. It is just to be noted that these are risk factors to be factored into your clinical judgment, to be determined as to whether you feel it's appropriate for them to be seen in the clinic. Having said that, many of our patients going through cancer treatments currently are immunosuppressed, and it may be better off for them to be seen not in the clinic. Next slide. So this is where oncology telerehab really comes into play, and I'm going to be focusing the rest of my talk on oncology telerehab. Next. So in the past, telerehabilitation has not been widespreadly used, and access has been slowly growing. Traditionally, it has been used as a tool to facilitate best practice and care in rehab. It's been used to improve quality of care and patient outcomes, and it has not been a replacement for in-person care, and it does not replace the need for in-person care. There was some growing evidence for its use, but there's currently not a large amount of evidence for clinicians to go for best practice guidelines. And there's some issues as to whether telerehab was covered in certain state practice acts, and also many payers in the past had not been covering telerehab. And then things changed with the COVID pandemic, and we're working to catch up and to adapt. There's obviously a steady increase in rehab service delivery and demand for telerehab care, and a rapid growth in providers and companies providing technology to be able to provide telerehab services. Issues still remain, however. Not all state practice acts freely allow telerehab services. Kentucky does. Medicare still does not cover telerehab services for PT, OT, and speech. But there is a bill that has been introduced and hopefully will pass called the Connect bill that will allow for that to happen. So there's some advocacy there that we need to be working on to get that done. In Kentucky, telerehab is covered by Medicare Advantage plans, TRICARE, and Medicaid. So that is good news. The evidence for efficacy continues to grow. I'm going to touch on that in my next couple slides. But there's still no competency standards for clinicians, and telerehab is not appropriate for every patient. But in the wake of the COVID pandemic, for individuals with cancer and other patients that are immunocompromised or unable to travel, a virtual visit with a therapist that they can trust is a great option to have. Next slide. So research supporting telehealth has grown significantly in the past 5 years. And I'm just going to give a high-level overview of the results of these 5 articles. One of them, Dr. Savoie already touched on. These particular articles were chosen for their high-quality study designs that utilize core principles of telerehab, and they demonstrate a high level of evidence. There are other studies out there, and the body of evidence for telerehab is growing. Next slide. So who can telerehab help? From these particular studies, evidence shows telerehab is feasible and acceptable for adults with breast cancer, advanced stage cancer who have functional limitations and pain, head and neck cancer, and patients with cancer-related cognitive dysfunction. Keep in mind there is additional evidence out there for other populations, specifically hematologic population and just other populations in general, and the evidence is growing, but these 5 articles in particular discuss these specific populations. Next. So how can TELEREHAB help? These articles indicate that cancer rehabilitation can improve patients' function, coping and problem-solving skills, quality of life, cognition, likelihood of being discharged to their home. It can decrease cancer-related pain, fatigue, anxiety and depression, days spent in the hospital. And finally, from these studies, there was an overall high patient satisfaction with care and with the therapist-patient relationship. Next slide. So what don't we know? We don't have evidence-based best practice guidelines for cancer rehab. So what do? We follow best available evidence and identify principles of cancer rehab best practices in key research for TELEREHAB. So in other words, we can extrapolate from these key articles and other articles like this, best practices and then adapt them to our populations and our specific situations. Next. So which patient cases or scenarios are best suited for TELEREHAB? Well, as Dr. Nelson said, cancer does not wait for COVID-19, and many of these patients are having non-elective surgeries to remove their cancer. So we can do TELEREHAB prehab education to instruct them on how to prepare physically for their surgery, and as well as what they can do in the immediate days and weeks post-op to help improve their function and their ADL performance status. We can also do prospective surveillance screening, education, and intervention through TELEREHAB. Oftentimes in our clinics, we usually will see these patients every 3 months for the first year after their diagnosis to screen for late and lasting effects that may impact their function, such as radiation fibrosis, lymphedema, neuropathy. And these are perfect visits to be able to perform via TELEREHAB, so that if we can identify a problem via screening that requires an urgent visit or a physician callback, we can identify it and get it taken care of before the problem becomes out of hand. Next slide. On this slide is a list of health conditions or impairments related to cancer and its treatment that we can also address with TELEREHAB visits. I'm not going to go into detail with everything on this list, but if you have questions later during our question and answer session on how we can specifically address these through telehealth visits, please ask during our question and answer time. Next slide. So there are some instances when TELEREHAB is not appropriate. One example is when patients need supervision to complete their therapy sessions, and it wouldn't be safe for them to participate alone, such as patients who require monitoring of vitals, patients who are high fall risk, or patients with cardiac comorbidities. And there are other examples listed here as well. Next, yep. So this is just a case example. This is a 45-year-old female who was diagnosed with endometrial sarcoma in July of 2020. She underwent neoadjuvant chemotherapy with Taxotere and Gemzar, followed by a total hysterectomy with a pelvic lymph node dissection in February of 2020. I'm sorry, she was diagnosed in July of 2019 and underwent surgery in February of 2020. So she presented for her initial TELEREHAB visit in April 21st. Her primary complaint was bilateral knee pain and swelling that had come on actually in March. She had spoken with her oncologist, who actually had seen her prescribe 2 rounds of prednisone to address the swelling and pain, which helped some, but was still there, and she was having functional limitations with walking and climbing stairs. So she was very active. She was doing, boot camps and everything before it, no pre-morbid history of knee pain, any orthopedic issues beforehand. So her goals were to get back to exercise and climbing stairs. So the therapist, using DoxyMe software, was able to identify just via observation, just was looking for swelling, discoloration, was able to watch her do several movements, different activities, was also able to look at and notice she had full hip and knee range of motion through the DoxyMe measurement software. There's actually software built in where you can do goniometric measurements. She had a full squat on a functional movement assessment, and then the patient was actually able to palpate and feel and tell the therapist where she was actually tender. So based on that, there was an initial treatment plan given. Some education was given on the likely etiology of the condition, As we know, taxotere is one that can cause some joint swelling. And so likely, since there was no pre-morbid history of joint, and some of the, had the patient do several things that mimic special tests on the screen. So we're able to, kind of that along with the oncologist input, decide that that was probably the etiology, and had the prednisone can also make her a little bit weaker through the muscles, and that was one of her complaints. So given her stretches, progressive walking program, core strengthening exercises, and also some quad strengthening, and educated her on body mechanics, home exercise program, and progressing slowly, because she had tried to get back to exercise too quickly and it aggravated things before. So the plan is to see her once a week for 4 weeks to progress her strengthening program to return to prior level of function. So this is a perfect example of somebody that could benefit from telehealth, just to slowly progress her and get her back to function, since it's primarily going to be an exercise program, not a lot of manual therapy, and she's going to be able to get back to her prior level of function. Next slide. So returning back to this slide, we've already talked about past and present, so role of telehealth. So let's talk about future. If there's one good thing that has come out of the COVID pandemic, it is putting telehealth and telemedicine in the forefront. And for the oncology population, this is key. This is a great advancement. Pandemic or no pandemic, this is needed for this oncology population. Many of the barriers to rehab for this population, which include finances, transportation, medical status, can be overcome with telemedicine. When these patients are able to connect with their trusted rehab professional from their home, they'll be able to be more adherent to their home program, and we'll be able to check in with them over the long term to check for any lasting or late effects from their cancer or cancer treatment. Patients are going to now expect this level of service, so we're going to need to be able to cater to this. So COVID-19 may be going away, hopefully, eventually, but telemedicine and telerehab are here to stay, and we're going to need to be able to continue research and advocate for this to show its value to patients and payers alike. Next slide. And next slide. Thank you. And so now we're going to open it up for questions.
Okay, we have a question right off the top. Let me get my camera back on. Either way you want to look at me or not. But okay, first question. For patients who need lymphedema therapy, do we need to take extra precautions secondary to COVID-19 since it's all manual therapy? Anyone can take that.
Yeah, I can take it. Yes. So in our clinics and in every clinic, every patient, no matter who comes in, we are taking extra precautions. So every therapist is wearing masks, gloves. There's certain every patient who comes in they're staying in their car until the therapist goes out to get them. When the patients come in, they wash their hands right away. Therapists are obviously washing their hands in between, wiping down every piece of equipment in between patients. There's only one patient per therapist allowed in the clinic at each time. So there's very much precautions being taken. With manual therapy, it's wearing gloves, it's wearing masks. Governor Bashir is now with opening where, patients are welcome to wear masks. We're not providing masks for patients, but they're welcome to wear their own masks. But yes, providing lymphedema therapy is very hands-on, but you just wear gloves and mask and change your gloves, obviously, between each patient, and wash your hands, and all of that is standard.
Okay. Well, that kind of brings me to a second question, which I think you kind of touched. How do you maintain your social distance with patients? And this could be inpatient or outpatient.
Yeah, I can take that question too. I think from a provider patient standpoint, that 6 feet distance for a physical exam just cannot exist, essentially. So thus, clinics are going to those measures that Audrey mentioned. At least in the clinic space, we are also doing the same thing where the patient stays in the car and you call them when their appointment is ready. Everything within the clinic, besides having that patient provider contact, is going to be try to be maintain that 6 feet as well, such as check-in, such as going to your patient room. There's going to be as much of that 6 feet maintained as possible in that sort of scenario.
Okay. Have one concerning telehealth or telerehab. Audrey, you said there were no national guidelines for telerehab, but for each facility or states, are there guidelines or toolboxes that are available for folks?
Yes, no, and there are, you know, so the APTA and the AOTA, they have special sections on telerehab and telemedicine. So when I say there's no national, there's not a lot of guidelines out there, but they're starting to get more. And there are some resources out there, and I can actually, you know, send those out. But I have actually I've got a couple written down here. But the APTA, their section on telemedicine and telehealth has a ton of resources that that they're looking for. So that's the first place I would go, because they actually have a great the whole section that they've got. They had a they had a new thing that just came out there, American Physical Therapy Association, telehealth and physical therapy in light of COVID-19. It was in the PT in Motion, March of 2020. That was a great article. So I can post those if you, I can send them to you, Jerome, if you want to add them on. I have a couple of resources, and they have some toolboxes of how you can get like clinician training, and you know, a lot of the softwares have clinician training on how to use their particular softwares, but best practices and how to, you know, quality of care. A lot of the telehealth special interest group within APTA has a lot of toolboxes that you can use.
And just to kind of piggyback on that, there haven't been any national guidelines on criteria specifically for cancer rehab patients. So essentially the guidelines that exist are for a broad audience of patients, and then you have to take that into consideration for cancer patients specifically.
True.
Okay. Are speech therapists at greater risk with head and neck patients since they are mostly coughing, especially?
I can take this one. So, for example, at Cardinal Hill, you're right, it is a significantly increased risk because of the way the particles and where the virus lives in the oropharynx. So most of them now are using N95s, a secondary mask covering, face shields if needed. At UK, unless someone did have one of these urgent head and neck issues and they had a tracheostomy, their therapy was actually placed on hold until restrictions will allow them to come back in. Now, if there's still an urgent thing that needs to be worked up, a worsening dysphagia or something similar, we can still do that. But you're correct, they are at greater risk. So the N95s have been in more use with the speech therapist than probably some of the other therapy disciplines.
Okay. Are there any suggested applications, I guess, for your telephones or computers for patients to track their progress that can be emailed to the rehab facilities?
So we utilize a Strive home exercise program. That's the software that we utilize, and we email. It has a tracking form with home exercise program that we can actually interface with our patients that way. If that's not an option for your particular facility, sometimes you can just email, like I've had my patients use like MyFitnessPal, and then they can email it to me. Just, you know, their progress. If they, so there's cancer, or there's logs, sorry, not cancer. There's also some different apps that can be used that they can just email, they're able to share. And if you share your email, they're able to share their progress that way. So it doesn't necessarily have to be something super formal, but there's different iPhone apps that are out there that they can share.
And that would probably be a departmental decision, you know, for wherever the specific therapist works, going to their supervisor and management of rehab to discuss like what could you put into play, because it is a great idea for patients to do that for them, for their progress.
Yeah. And MedBridge has another great one too. MedBridge is another fantastic one.
Okay. Are there any more questions out there?
Jerome, I've got a couple that I'd like to pose.
Okay.
The first one has to do with if you're a provider or a clinical support staff and you have a patient that you feel like would benefit from Oncology Rehab, how would they refer that patient? And then if a patient is interested and hears about Oncology Rehab, how would they be able to get a referral?
I know, dependent upon insurance, you can self-refer. For some insurance companies allow that. So you can literally like Google, if you're in Louisville, Google me, or Google Dr. Savoie, or Google any sort of rehab organization, including court, and you can get some self-referrals, at least to the physician. Now for physical therapy, occupational therapy, and speech therapy, you traditionally have to have a physician referral. And that can be through your primary care physician, that can be through any of your oncology providers. Really any physician involved in your care can provide a referral.
Yeah, and really that's for an outpatient physical therapy or occupational provider. Those are just for like your Medicare, your federally funded. Other insurances, you don't have to have a referral, but again, if you're a provider wanting at least, like, you could just look up the place that you wanted to send to. Like for us, it's like our website, and there's a place that you can just submit a referral right online. Yep.
For my patients that have self-referred, it's generally come from the website. So most folks are tech savvy enough now to be able to Google Cancer Rehab, and then depending on whatever they're closest to, just utilizing the phone number to call in.
And then a second question has to do with TELEREHAB. And I saw in a couple of slides it talked about, or it mentioned insurance and coverage, but can you talk a little bit about coverage, insurance coverage for TELEREHAB, and also on the flip side about provider reimbursement?
Absolutely, yes. So yes, so what we're finding is that most insurances do cover TELEREHAB similar to an in-person visit. There are some that are costing it a little bit different, because sometimes you have to code it with a different code, because you're coding it as to where you're performing the visit, because most of the CPT codes are coded as to you're performing it as an in-office procedure. So some insurances might be coding it at a little bit less value, but some are reimbursing it just the exact same as an in-office visit. As far as patient payment, it's going to be just subject to any kind of copay or deductible, just like any other in-office visit. But a lot of times for patients that are undergoing cancer treatments, if they're in the same year as their cancer treatments, then a lot of times if they've met their deductible typically with their surgery or their cancer treatments, and so sometimes even they're out of pocket. So a lot of times their fee for their therapy is nominal. But we always check those benefits, what they would be beforehand, and let the patient know what their responsibility is. But as far as reimbursement, what we're finding is we are getting reimbursed for most of the insurance plans. The interesting thing, what we're finding, and it's new, right? It's new, but our visits aren't as long as our in-person visits. So whereas like we would see people for a full hour in person, it's just not quite the same. You just can't quite stretch that full hour on TELEREHAB. So it's an interesting. It's going to take some time to kind of see how that plays out as we do it more. And as our therapists get more comfortable and more confident and try to come up with things, but it's just not that. It's usually about a 45-minute session versus a full hour.
I think it'll be interesting to going forward to see if insurance companies continue to cover TeleRehab. I know at some point insurance companies may call it quits on coverage. I just don't know what the next month or 2 or 3 are going to show.
Yeah. Well, and I think we're going to really need to have the research to prove it, to prove that it helps and prove that it works. So I'm thinking that we need to really so for any therapists that are on the call, I mean, get those success stories, even if they're not, even if we need the high level research, but any kind of success stories you're getting, any kind of, good feedback you get from your get any of that, because any of that's going to help influence and promote advocacy for how TeleRehab can work going forward.
Okay, this is a great question. We know that COVID-19 has some long-term side effects where people are having trouble still breathing. Are you guys seeing any rehab of those patients, or have you yet, or do you expect to see some?
From the acute perspective, there are folks that are recovering now who have taken that path from their ICU or PCU hospitalization and been in such decline that they require an inpatient rehab stay. So when they have been recovered, when they've demonstrated 2 negative tests for COVID, then they're typically deemed okay to transfer. Here in Lexington, Cardinal Hill has a separate COVID unit that they're using to make sure that the use of PPE is minimized and that patients are not overly exposed in any kind of way. The transfer of materials between room to room is kept to a minimum. So the folks that we're seeing that are recovering, that need the rehab, have been using the inpatient pathway. I would suspect that at some point in the near future, we're going to start seeing some of the folks with maybe less pulmonary issues, but still having long-term, who may need a touch of outpatient pulmonary rehab when that becomes a viable option again.
And I think a lot of these patients who are severely debilitated, they're showing signs of critical illness, myopathy, and critical illness, polyneuropathy, that type of patient who are going to the inpatient rehab.
Okay, great answers. All right, it doesn't look like there's any more questions, but I want to thank you for such a informative, timely presentation amidst these uncertain and new normal times that we're having with COVID-19. I want to thank our moderator, Ms. Sherry Toll, for doing a great job today. And thank our presenters once again for stepping up and presenting on this topic. So thank everyone for joining. And one last question just came in. Is this being recorded and how can I find it? Yes, this is one question I can answer. It is being recorded. And if you're an affiliate member, it will be saved on our McCann resource portal. If you're an affiliate member and you do not have access to the portal, you can send me an email. It's jerome.farley, that's Jerome with an N, at uky.edu. I will also be sending out a short survey after this presentation that I will then share with the presenters. So if there's no more questions, thank everyone again. Be safe out there. Bye-bye.
Thank you, Joanne.